So what does it test in particular? So urine or gastric aspirate can be tested by reduction of Paraquat cation to a blue radical ion in the presence of alkali and sodium dithionate. Okay. So how I usually remember in my PG days is sodium is usually Na, right? So instead of Na, I just put S for sodium. Okay. So thio means sulfur, right? So dithio means 2-thio, it's triple S. This is how I used to remember in my college days. Okay. So I will add some sodium bicarbonate and triple S. The triple S is nothing but sodium dithionate. This is how I remember for my exam. So add the alkali such as the sodium hydrochloride to 10 ml of urine or a gastric aspirate until the pH is about 9. So approximately half to 1 teaspoon of sodium bicarbonate. We just take a 1 teaspoon of soda bicarbonate and we'll start mixing with the urine. That's all it is. And some small spatula blade of sodium dithionate, and we'll mix that gently and we'll wait for the result. Okay. But understand, Paraquat poisoning is quite rare compared to your sepsis and other trauma or other cardiac patients in your ICU, right? It's a relatively, the incidence of Paraquat poisoning in your ICU population is actually less. For that reason, the sodium dithionate, even if your hospital has this particular sodium dithionate, it would have not been used for a longer time, right? If it's not properly stored, if it's not properly covered, the sodium dithionate can deteriorate. Okay, if you are using such kind of sodium dithionate which is not stored properly, which has poor quality of sodium dithionate, this test can become negative also. Okay, false negatives also. So you need to use a properly preserved or a fresh sample of sodium dithionate. Understand this. It need not be always fresh, but understand it has to be at least stored properly. So in your exam, if you want to tell, you can use this number saying that 1 gram of sodium bicarbonate and 1 gram of sodium dithionate to 10 ml of urine. But in your clinical practice, you won't literally measure all these things. So 1 tablespoon of sodium bicarbonate and 1 spatula spoon of sodium dithionate is what we take and we mix and we see. That's all it is. Okay. Otherwise, you can say as 1 to 2 ml of 1% sodium dithionate to 1 to 2 molar sodium hydroxide to 10 ml of urine. Okay. So basically there will be some sodium bicarbonate, and next is a sodium dithionate. Take 1 teaspoon from here, 1 spatula spoon here, and in 10 ml of urine you are going to mix it and wait for the color reaction. That's all it is. So view the tube against white background. A blue or green color in the solution denotes the presence of Paraquat, and this confirms the diagnosis. Sometimes if the concentration is very high, this blue can even turn into black. Okay. So understand, if it's still the color has not changed, it means that concentration of Paraquat is literally 0. A mild change is around 3 micrograms per ml, a bit more change is 10 micrograms per ml, and 30, that's the blue color is 30 micrograms per ml, and a darker blue it's 100 micrograms per ml. Okay, so this will not give you any number. Okay, you need to just take the test tube and look at the white background, and you need to come to a conclusion that possibly the content will be somewhere around 10, 30 or 100 micrograms per ml. Okay, so this is semi-quantitative also. Okay, the qualitative treatment, the qualitative test which you are doing is actually semi-quantitative also. That's what I'm trying to tell you. Okay, so high Paraquat concentrations may turn black, and the tube should be repeated with a diluted sample to confirm it. Okay, so by this method you can actually detect 2 microgram per ml also, and this can be held as a semi-quantitative method also, and this has been proved by multiple papers including the Widlop in 1976 and Berry and Grove in 1971. So next method is your solid phase extraction. So the urine, serum or plasma can be tested for Paraquat using in situ reduction on a solid phase extraction cartridge. This is done by Bullen and Mahaler in 1987. Okay, plasma can block this kind of cartridges because it's usually thick, right? So it should be filtered through a 0.45 microM syringe filter before the test. If you are using serum, it's literally dilute. It's literally very viscosity of serum is very less. So serum does not require this kind of pre-treatment. Okay, unless the serum is very cloudy. So this can detect Paraquat even more in a very minimal quantity. 0.1 microgram per ml in a 2 ml sample itself can be detected by solid phase extraction. Okay, so this is not used clinically, dear friends. This is only for your exam purpose. In case you get a Paraquat poisoning, they might ask you about the solid phase extraction technique also. Okay, ideally a positive control should be carried out at 0.5 microgram per ml. So these are the various methods: the liquid extraction technique, magnetic solid phase extraction technique, needle tip based solid phase extraction technique, and SPE combined with your matrix assisted laser desorption ionization mass spectrometry. It's called as MALDI, MALDI. Okay, nowadays for other lab things also we have started using this kind of Marley techniques, okay. So magnetic dispersive solid phase extraction, this MDSPE. So these are the various other solid phase extraction. This gives you additional mark if you are able to answer this in your exam, okay. SPE stands for solid phase extraction. So this is about the qualitative and semi-quantitative. Now we are coming to quantitative determination of Paraquat. Why should we even quantitatively determine this? Because the more amount of Paraquat he has consumed, then you will know that the fatality is very high, the prognosis is extremely bad. Not always the patients will be able to tell you the exact quantity he has consumed, right. In our example, the patient informed us that it is 50 ml roughly, right. Most of the time they will not be able to tell you how much quantity they have consumed, right. So you need to have a quantitative measure if at all you are going to prognosticate the, right. So quantitative measurement is done in the plasma, understand that. The solid phase extraction is done in serum, okay, it's better than serum, but the quantitative is done in plasma. The sample must be taken at least 4 hours post ingestion and should be stored in plastic, not glass tubes. Understand, don't wait for your quantitative measurement to start the treatment, okay. Just a qualitative measurement is more than enough to say whether the Paraquat is present or not. It's more than enough for you to start treating the patient. Don't wait for 4 hours, don't wait for your confirmatory quantitative measurements and then start your treatment, right. In qualitative measurement, if the answer comes yes, or by history wise the answer is yes, do start the treatment, okay, start it, okay. For quantitative is only for prognostication. And the sample must be taken at least 4 hours post ingestion and should be stored in plastic, okay. It should not be stored in glass tubes. Now the question is, why should we not store them in glass tubes, okay. The first and foremost thing is glass tubes can break, right. The moment you drop it, you break it and the Paraquat spills on other people, spills on your own the caretaker, it's going to be very detrimental, right. And moreover, the Paraquat itself can react with the glass tube, okay. So Paraquat should not be stored in glass tube because of its alkalinity. It reacts with glass, leading to degradation of glass. And absorption, Paraquat can get absorbed to the surface of glass. So more Paraquat, if they get absorbed to the surface of the glass, the concentration of that particular ingredient can go down, okay. So in your quantitative measurement, the number can go down. And other things is safety concerns, because glass is fragile and if breakage occurs, Paraquat being highly toxic could pose a serious health hazard if spilled or inhaled, okay. And for safe storage, plastic containers like polypropylene and polyethylene are preferred because they are less reactive with Paraquat and are more resistant to breakage. Understand, dear friends, in your exam, most of the time the examiners will assess you in terms of whether you are doing any mistake or not. Even if you are not able to answer properly the next step of a patient treatment, you should be thorough what you should not do, okay, because do no harm is your Hippocratic oath, right. So you should not do any harm. So you should know what things you should not do, okay. So one such thing is, you should never store or transport Paraquat in a glass. So quantitative measurement, plasma should be analyzed and not serum, because serum Paraquat concentrations are approximately 3-fold lower than the plasma in total. So use plasma for quantitative measurement and serum for qualitative measurements in the solid phase extractant technique, okay. Otherwise, you just use a urine sample, just 10 ml of urine, mix it with your soda bicarb with sodium dithionite and it will give you a result, right. In a semi-quantitative way, it's more than enough. So this is the quantitative measurements. The second degree spectrometry, which can measure, the lower limit of detection is 0.5 to 1 microgram per ml. And gas chromatography, mass spectrometry, the lower limit of detection is 0.05 microgram per ml. And HPLC, the high performance liquid chromatography, the lower limit of detection is 0.001 micrograms per ml, okay, after conversion to a dipyridine derivative. And next is your liquid chromatography, electrospray ionization technique, okay, mass spectrography. The lower limit of detection is again 0.0005 micrograms per ml. A very minimal quantity can also be appreciated if you use this kind of high-end techniques. These are only for your exam purpose, okay. These are not, we are not using this kind of things in real-time practice, because when the patient comes to you with a deliberate self-harm, the quantity is going to be extremely high. It can easily be looked up in your urine sample itself, okay. If the patient has consumed very minimal quantity, very minimal quantity, then the patient is more likely to survive, right. What is this SIPP? So if the question comes on Paraquat poisoning, whether it's in your viva or in your theory, you are supposed to tell about this SIPP. SIPP is nothing but severity index of Paraquat poisoning. It's calculated by multiplying the concentration, the plasma concentration, by the time since ingestion, okay. If that plasma concentration multiplied by time since ingestion is less than 10, this predicts survival. 10 to 50 predicts death from lung fibrosis. More than 50, death can occur from circulatory failure itself. Okay, basically, if it's more than 10, the patient dies. If SIPP is more than 10, the patient dies. So, prognosis, the prognosis in patients presenting more than 12 hours after ingestion, more than 50 ml of Paraquat 20% with a positive plasma dithionite test or SIPP more than 50, it's extremely poor prognosis. Treatment should focus on symptom control, palliation, end of life care. There is no way you can save this patient at all. Okay, understand, just a lung transplant is not going to be the treatment. The prognosis in patient presenting with less than 6 hours, ingesting less than 50 ml of Paraquat, faint positive dithionite test or the SIPP less than 50, there is a chance you can try saving the patient because the prognosis is still poor. Okay, I said you that SIPP less than 10, there is a chance to survive. Less than 50 is even a higher window for them, right? So you can try saving these people. If the SIPP is more than 50, there's no point in offering much treatment for them. The treatment should go towards palliation only. But SIPP is less than 50, you can at least try. Okay, so but prompt multimodal treatment with volume resuscitation, oral activated charcoal. If there is no oral activated charcoal, you can use the Fuller's Health also. Hemoperfusion or hemodialysis, intravenous corticosteroids, acetylsalicylate, N-acetylcysteine, defruxamine and vitamin E, all these can be considered on a case-to-case basis. Okay, if SIPP is more than 50, no point even treating the patient. Okay, only palliation is required. So, this is one thing which I want to just cut, copy, paste and show you, dear friends. This is a lines from Goldfrank textbook of toxicology, direct lines from Goldfrank textbook of toxicology. So, it mentioned that when the dithionite test is conducted on plasma, like add 200 microliters of 1% sodium dithionate and 2 molar sodium hydroxide to 2 ml of plasma from the patient. Basically, when you're performing the dithionite test, a positive result is specific for death. Okay, very harsh words, you know, it's a very, very, very harsh words directly from lines from Goldfrank. I'm mentioning these lines because you need to understand the seriousness and severity of a person who has consumed Paraquat. There is no way you can save the patient if the SIPP is high. Even 5 to 10 ml is extremely fatal, understand that. Okay, but a negative test does not exclude the severe poisoning or death. Okay, very rarely you find this kind of lines in your textbook. Positive result is specific for death. Okay, so general supportive measures. If the patient is conscious, cooperating and not vomiting, then administer activated charcoal 50 to 100 grams for adults and 0.5 to 1 gram per kg body weight in children. And in the absence of activated charcoal, you can use the Fuller's Health, okay, 15% suspension or bentonite, 7.5% suspension, okay, 100 to 150 grams for adults and 2 gram per kg body weight in children can be considered as an alternative if at all you don't have a charcoal. Early management, IV fluids. Why IV fluids? I told you that the kidney will identify that Paraquat does not belong to your body and it will take all the steps to excrete it. Okay, it will start secreting, the proximal convoluted tubule will start secreting the Paraquat into the lumen of the nephrons. Okay, so but for that there should be adequate fluid in the body, right? Adequate hydration should in the body. So IV fluids, the kidney is the major route for excretion of Paraquat and thus the renal function must be closely monitored. Okay, so if the Paraquat is on the high concentration in the blood, you can go for hemodialysis and hemoperfusion as such. Okay, the mouth care for ulceration inflammation is required. Nil by mouth if there is suspicion of oropharyngeal or esophageal injury. Early RT Rayleigh tube should be considered, taking care to avoid additional mucosal damage. Avoid supplemental oxygen unless significant hypoxia exists because oxygen enhances Paraquat toxicity. Okay, if you want to remember one word or maybe 2 words about Paraquat poisoning, word number 1 is oxygen enhances Paraquat toxicity. Do not give oxygen unless it's extremely required. Okay, number 2, the fatality rate is almost 100. These are the 2 things which you need to remember about Paraquat. So, management of acute renal failure, start with your hemodialysis in patients who develop symptomatic acute renal failure. Okay, in some way or the other, you need to take the Paraquat. Okay, since the prognosis of such patient is generally poor, this procedure is unlikely to change the overall outcome. Okay, so very deep statement, dear friends, very deep statement. Understand, if the patient is presenting with you or the patient develops acute kidney injury, it means that the amount of Paraquat he has consumed is very high. Okay, so I already told you, if the patient has consumed adequate or more amount of significant proportion of Paraquat, there is no point in giving much of treatment. Only symptomatic treatment of palliation only is required. Okay, so a patient who is going towards an AKI because of Paraquat, you can support the kidney function by hemodialysis, but the time has already passed. right? The patient is nearing his death. So to whether to give a hemodialysis for the patient is a question you need to discuss with the family and take a call on it, because it's not going to have any mortality benefit. So flowchart for early management of paraquat poisoning. So significant paraquat ingestion suspected on history or examination, and the patient is having vomiting. If yes, control the vomiting with some ondansetron 8 mg IV or pour chlorperazine. If there is no vomiting, you can administer activated charcoal 50 to 100 grams or 0.5 to 1 gram per kg. Okay. Immediately start with your IV fluids, very important, analgesics, and avoid supplemental oxygen if possible. Okay. Immediately do a paraquat spot test, the urine or gastric aspirate. If it turns to be negative, you need to repeat the test after 6 hours. Even after 6 hours, it's going to be negative. You can even discharge the patient if ABCD is completely normal. Okay. See, urine spot test about paraquat tells only about paraquat. It doesn't mean that the paraquat is negative, discharge the patient, right? I'm speaking about paraquat toxicity. You need to check for other toxicities if your history and clinical examination supports that, right? So if your urine and gastric aspirate is positive, then plasma paraquat levels can be taken after 4 hours, that is 5 to 24 hours, and repeat it at 6 hours, okay, just for only support to manage. And you need to put your survival probability curve for prognosis. You need to calculate your SIPP as well, okay. The supportive management is only analgesia, supportive renal function, palliative care for those with a poor prognosis. So this is the chart which you need to draw right in your exam as well. So what is that survival curve which I mentioned? It's the relationship between the paraquat plasma concentration and patient survival. Okay, so understand at the end of 4 hours, okay, the plasma level of paraquat comes to be 1. Okay, so the line comes somewhere here, right? Okay, so the chance of survival is somewhere around 50 to 70%. Okay, at the end of 4 hours, the plasma level is 1. Okay, it's somewhere around for 50 to 70%. Okay, for example, the patient comes to you at 8th hour. Okay, at 8th hour, see the plasma level is somewhere around 2. Plasma level is somewhere around 2. The chance of survival is only 15%, okay, or at 8th hour, the plasma concentration is somewhere around 4, take the plasma somewhere around 4. If it's 4, the chance of survival is less than 10%, understand that 4 micrograms per ml is extremely less, right? Do you remember the test tube which I showed you, the urine test which I showed you, and it's a semi-quantitative test, okay. We were discussing like 30 micrograms per ml and sort of things. That's a urine value, of course, it's a urine value, right? So if you do a plasma level and it comes to be somewhere around 5 micrograms per ml or 4 micrograms per ml, then the chance of survival is very less, okay. So this is the relationship between the paraquat plasma concentration and patient survival. Once you get a plasma level of paraquat and you know the time since conception, you can draw this curve and you can very well understand that what is the chance of recovery. So this is by Hart, TB et al. In 1984, and this stands true even now. So other potential treatments is one way is enhanced elimination of paraquat. Understand, hemodialysis is for acute renal failure, it does not eliminate paraquat. Okay, so for paraquat elimination, you need to do hemoperfusion. Okay, efficiency is still controversial. Okay, while charcoal columns are very efficient at removing paraquat from the blood, paraquat is rapidly distributed to other tissues and redistribution back to the blood relatively slowly. Okay, for example, you do a sled for a patient for 6 hours. After that 6 hours, again, whatever paraquat material present in the tissues will get recirculated to the body. Okay, and it happens very slowly. Okay, so the moment it comes to the blood from other tissues, the liver, kidneys and the lung will start taking up on a priority basis, and the insult of this kind of lungs and kidneys is going to continue. So even if you do a slide, it's not going to be much of a benefit. I'm saying even if you do your hemoperfusion, it's not going to be much of your benefit. But to certain extent, since we don't have any other treatment options, to certain extent, whatever minimal effect it has, we need to give the benefit to the patient. For that reason, you still perform a hemoperfusion. Okay, what time you should start your hemoperfusion? My answer will be at the earliest. Okay, the moment the patient has consumed a paraquat, within 1 hour there's peak absorption from the GI tract, right? So in 1 hour itself, if you start, the particular paraquat will be in the blood, will be easy for hemoperfusion to remove. The more time you allow, the more tissue distribution happens, so less paraquat will be available in the blood for hemoperfusion to remove. Okay, so hemoperfusion should start at the earliest. Again, I am telling you this, dear friends, emergency physicians who have handled this paraquat will understand. You are speaking about hemoperfusion, some sort of dialysis in a patient who is sitting comfortably and very normal in front of you. right? The family is bringing to you a patient whose ABCD is completely normal and he says that he has consumed around 25 ml of Paraquat. So you need to start your hemoperfusion even if ABCD is normal in this patient, and you need to inform the family that this is extremely fatal, okay? And in spite of you starting hemoperfusion, still the fatality rate, the mortality rate is very high, okay? There's every chance the family can sue you telling that it's because of your treatment the patient is completely gone now, right? So you need to sit, document it, possibly with a video and audio evidence, get a proper signature, and then handle this patient, because these are MLC, okay? These are medical legal cases as well, right? Toxic levels in the tissues occur early in the course of poisoning. So you need to start your hemoperfusion at the earliest in the ER itself. When considering the use of hemoperfusion Paraquat poisoning, note that patients who have ingested borderline lethal quantities of Paraquat or have survival probabilities between 20 to 70% and presents to you in less than 4 hours post-ingestion, then they may benefit from hemoperfusion. Okay, since the Paraquat may not have distributary tissues and lugs in a toxic quantities, and even small differences in the Paraquat level may affect survival, may benefit the survival. Only for those minimal benefit, we need to do this hemo concentration techniques, hemofiltration technique. So this has to be done at the earliest. Patients who have taken many times the lethal dose of Paraquat or who have very poor prognosis on survival probability curves are not helped by hemoperfusion. Understand, hemoperfusion is not a lifesaver. Okay, it's not that he has consumed 50 to 100 ml of Paraquat and hemoperfusion can save him. Not that way. Okay, this patients who come under this moderate category, only they can be tried for this hemoperfusion. If they are a fulminant category who have consumed a lot of Paraquat, then there is no means you can save the patient at all. Okay, said by Hamston and Pond in 1988, and it still stands true. There is no evidence that the use of continuous hemoperfusion or hemofiltration is life-saving, but it may prolong the survival. That's all it is. Okay, so this may allow the use of other treatment modalities to be concentrated as well. So the scheme, the proposed scheme, how to use it is 7 hemoperfusion sessions, 6 to 8 hours duration each, started within 4 hours of ingestion and maintained until the plasma Paraquat levels is less than 0.2 milligram per liter. Okay, so this is done by the Oliveira at 2008. Okay, 7 hemoperfusion sessions, 6 to 8 hours each. You can remember a 7 hemoperfusion session, 7 hours duration. Okay, started within 4 hours. So prevention and treatment of pulmonary fibrosis. So now, how to decrease the content of Paraquat inside the body? One is your RT, and you're going to give a adequate stomach wash with your activated charcoal, right? So after you activated charcoal, you're going to give a lot of IV fluids to maintain proper hydration. Don't overhydrate the patient, okay? So proper hydration so that you are enhancing the excretion, okay? And through hemoperfusion. These are the 3 techniques where you're going to decrease the content of Paraquat in the body, right? So whatever harm which is done for the patient already in the lungs. So how to prevent the pulmonary fibrosis? Patients with moderate to severe intoxication who do not die from early multi-organ failure often develop progressive pulmonary fibrosis. Okay, this leads to the respiratory failure and death within few weeks itself. Several treatment modalities have attempted to prevent this. The most frequent will be to suppress the immune system. Okay, so it is the suppression of immune system. I basically mean the cyclophosphamide and steroid therapy. Okay, so what is the cyclophosphamide steroid therapy? Where does it come from? Edelson et al. In 2003 evaluated 10 clinical studies. Mortality in controls and patients varied markedly between these 2 studies. Okay, the authors concluded that the result could only be regarded as hypothesis forming rather than conclusive. They wanted more studies to come up with this. Okay, so Lee et al. In 2014 evaluated the combined results from 3 RCTs with a total of around 164 patients. Okay, the result is still inconclusive. They said it's like maybe beneficial. So he also called for further RCTs to confirm whether it's really useful or not. So a large scale RCT with cyclophosphamide up to 1 gram per day for 2 days, methylprednisolone 1 gram per day for 3 days, and then followed by oral dexamethasone 8 milligram TID thrice daily for 14 days has been carried out. Okay, so this is what we are currently using also, dear friends. Okay, note it down. So 299 patients were randomized to immunosuppression, 147 immunosuppression, placebo was 152. There were no significant difference in in-hospital or 3-month mortality rate. Okay, but a Cox model did not support the benefit from high-dose immunosuppression, but suggested a potential benefit from subsequent 2 weeks of dexamethasone. Okay, So just by giving cyclophosphamide and methylprednisolone, they were still in an inconclusive way only. But if you continue the steroid therapy with oral dexamethasone for 8 milligram TID for next 2 weeks, then they had some potential benefit. Okay, so if you have started continuously. Okay, cyclophosphamide plus methylprednisolone continued with your oral dexamethasone. Okay, it was concluded that further research on dexamethasone is needed. Okay, this is said in 2012. Okay, so currently we have options to identify, we have options to test your qualitatively, quantitatively, and you need to counsel, do an MLC. You can give the charcoal for the activated charcoal for the patient, and early hemoperfusion techniques, and you need to support the other organ systems. Of course, you are not supposed to give more oxygen for this patient, and the fatality rate is actually very high. In spite of other things, you have a few other options to treat this paraquat as well. So one is to prevent the pulmonary fibrosis, you are going to suppress the immune system with your cyclophosphamide and your steroids. Okay, the dosages and techniques is already mentioned. What are the other things? Antioxidants. The major pathology is oxidative free radicals, right? So is there a role for antioxidants? Yes. Vitamin E, 300 milligrams twice daily per oral, or vitamin C to reduce the free radical toxicity. N-acetylcysteine, 150 milligram per kg over 3 hours, and 300 milligram per kg over 24 hours for up to 3 weeks. Okay, this will increase the intracellular glutathione concentrate. Okay, and next is desferoxamine, 100 milligram per kg over 24 hours to chelate iron. Okay, so glutathione is a good marker. So you need to increase the glutathione so that oxidative free radicals can be minimized, and you're going to decrease the iron because iron acts in the Fenton's reaction, increasing the oxygen free radicals, right? So you are using desferoxamine to chelate iron, which acts as a catalyst in the production of hydroxyl radicals. Okay. Next is salicylic acid, which can scavenge the hydroxyl radicals and inhibit the activation of NF-κB also. So these are other things which have only minimal benefits, but since this condition extremely fatal, whatever minimal benefit you can offer to the patient, better do it. Okay. In China, there's something called as a Zhubijing, a preparation made from 5 traditional Chinese medicines reported to have significant anti-inflammatory properties. Okay, so we need more papers whether this particular Chinese medicine can improve a mortality rate or survival rate in this kind of patients. Okay, so fingers crossed, researchers are going on this particular preparation, Zhubijing. Okay, next is in China they also use urinastatin in some hospitals supported by animal studies. Okay, you need to know about all these things. Coming to the lung transplantation, the famous question, whenever you see paraquat poisoning who has severe hypoxia where we are not giving oxygen, so the next option comes to our mind is going to be the lung transplantation, because the lung is going to suffer from severe inflammation and fibrosis, right? So the lung transplantation has been tried in patients with delayed respiratory failure, but it was largely unsuccessful. Understand this first. Because of prolonged elimination half-life of paraquat. Successful lung transplantation was reported when performed 56 days post-poisoning after 12 days of extracorporeal membrane oxygen therapy. Okay, so you need to wait literally for all the paraquat to go out of the body. Okay, till that time the patient is going to suffer significant hypoxia. Hypoxia itself can kill the patient, right? So as a bridge therapy, you can put the patient in ECMO. Okay, put the patient in ECMO, offer him good oxygen therapy for the patient, offer him good circulatory support for the patient. Make sure that paraquat is going out of the body, because once you put the patient on ECMO, you're not worried about the lung anymore, right? So you're not worried about the lung anymore. So some amount of oxygen you can give. You can prevent cell death because of hypoxia on that. Okay, you need to dialyze the patient for kidney support and stuff. Okay, so ECMO along with your CRRT, along with your other measures, you have to wait literally till all the paraquat goes out of the body, and then you can offer a lung transplantation. Okay, so successful lung transplantation was reported when performed 56 days post-poisoning after 12 days of extracorporeal membrane oxygen therapy. These numbers are random numbers, dear friends, because it depends upon what is the quantity, how much paraquat that particular person has taken in, and what was the measures he was supported with, and how much urinary excretion is possible, and what is the AKI scenario there. All these things matters. But the idea is, because of prolonged elimination happens, early lung transplant is going to kill the patient further. So coming to the summary, so once you receive this kind of patients, the diagnosis is usually made from history, right? And then you have the spot urine test. If it's negative, you're going to repeat it after 6 hours. The spot urine test is not qualitative, not quantitative. It's both qualitative and semi-quantitative as well. Okay, so even if the patient ABCD is stable, it's not that all patients will come with stable ABCD. I'm telling you, more than 30 to 40% people can come with stable ABCD there in your ER, right? So whatever presentation is, if the Paraquat toxicity is confirmed, do an MLC and counsel the family that it carries almost near to 100% mortality. Okay, but you can try your level best to save the patient with all the measures available if the patient has consumed little or maybe in coming under the moderate intake category. Okay, if it's fulminant, there's no use at all. And once the diagnosis is confirmed, you can go for a quantitative methods also to classify how much he has consumed. So once the diagnosis is confirmed, quantity is confirmed, meanwhile you're going to start your treatment also. Okay, you know what is the mechanism, right? And you know what is the first aid is, right? And what is the treatment wise, how are you going to proceed further? In first aid is always airway breathing circulation, use your activated charcoal, give some IV fluids adequately. Then the treatment option is, after your confirmation, you're going to start your hemoperfusion, okay, and do not give much of oxygen there. And what are the other methods there, right? Like antioxidants, how are you going to prevent the further lung fibrosis? By giving cyclophosphamide, by giving methylprednisolone, by giving dexamethasone, all these things you need to understand. And the no oxygen strategy there. And if you're planning for a lung transplant, the timing of lung transplant is very important. You need to make double sure that the paraquat is already excreted from the body. Imagine a situation where you have did a lung transplant, but some amount of paraquat is still inside the body, retained inside the body, and that particular retained paraquat is killing the new lung also. It's a very, very critical situation, right? So you should be double sure that the paraquat is moved out of the body. There's no urgency there. So the patient's already on ECMO for the bridge therapy and then proceed with lung transplant. No, never forget to do an MLC. And if the patient is completely saved, once a patient gets discharged, you need to ask for a psychiatrist consult as well. Okay, so this is paraquat poisoning for you, dear friends. Okay, thank you.